My name is Jackie Sable. I'm a member of the ECHO team, and I'll be facilitating today's session. A few announcements before we begin. If you've not already done so, please put your name, email address, and affiliation in the chat box. Please stay muted unless you're speaking. You can use *6 on your phone to mute and unmute, or the microphone icon on the bottom left-hand side of your screen. You may also use the chat for communicating. We realize that question and answer time is important to you, and we try to categorize and address as many questions as possible. But if there are any open items after the session, we will follow up via email. If you have suggestions for future COVID-19 ECHO topics, please share them via the chat tool, or you can email us at echo@psu.edu. Please remember that no personally identifiable information is allowed when we're discussing cases. We are recording these sessions, and we share the recording and all materials after each session. In the spirit of all teach, all learn, we will be on a first-name basis during the session. For those of you who are not familiar with the ECHO platform, our ECHO sessions always begin with a brief lecture followed by a case discussion. Cases could include a question or a challenge that you would want to address, and they're a critical component of the ECHO model. We encourage you to submit cases which could be related to patients, preparedness, policy, whatever challenge or situation where you would like to generate discussion and ideas. The link to submit cases is always included in our follow-up emails. For today's session, Dr. Andreas Achilleos will discuss outpatient monitoring and management, followed by a brief case. During the lecture, please feel free to put your questions into the chat. We have a team of specialists from Penn State online, and they help to field questions, but please remember this is an all teach, all learn environment, so everyone is encouraged to provide both questions and answers. We'll pause between the brief lecture and the case to address any questions. And with that, I'm going to turn things over to Andreas for our brief lecture.
Good morning, everybody. Thank you for the opportunity to give this talk today. I'll try to make it brief so there's plenty of time for questions. I'm an internal medicine provider. I do primary care at Hershey Medical Center, and I'm working with a group of other providers in our institution in family medicine and also institutional leadership to streamline the process of monitoring our patients who test positive for COVID-19. So what I thought I would do today is just review the disease spectrum that we see with COVID-19, and obviously our understanding of this particular disease is evolving as we go. I'm going to review some of the testing limitations and how that leads to a new patient classification called people under investigation or persons under investigation, PUIs, and how we streamline the monitoring of those patients as well. Mostly I'm going to focus on process, the model we developed for the outpatient monitoring of COVID positive patients and also PUIs. And I'm going to briefly mention our acute COVID clinic. I think there's going to be a different echo session on our COVID clinic, so I will leave most of that discussion for that particular session. Let's discuss a little bit the manifestations of COVID-19. There's no particular symptom or even constellation of symptoms that is diagnostic of COVID-19, unfortunately. And in the middle of an epidemic, we all assume that any person with URI may have COVID-19, and we treat them as such. What we have seen so far by monitoring these patients, we have verified that there is a huge range of severity in the illness. There is probably a lot of asymptomatic patients out there that nobody has been able to accurately quantify. I think current estimates range from 25 to 50% of totally infected may be asymptomatic. There are people out there with very minor symptoms such as malaise and headaches and sore throat. And then we see the very severely ill people who get admitted, intubated, and eventually succumb to the disease. Besides that range of severity, we have seen a range also in the duration of the symptoms. Some people have a very short illness. Unfortunately, some people have a very prolonged illness that may last for several weeks. It can also go through phases from what we have seen. We've known from other countries and other case series that there may be a peak in the morbidity or mortality from this disease around days 7 to 14. Patients initially may have a relatively mild course, and after a week, they may develop more severe symptoms, namely recurrent fever and shortness of breath that may lead to hospitalization. We've even seen some patients that were hospitalized during that period go home and then get worse again. So there is a wide range of disease presentation that we're still learning about. The fever, cough, dyspnea are the cardinal symptoms we look for. With limitations, case series show that fever may only be present in half of the patients. So we have to be mindful that not all of the patients will have a fever. Dyspnea is usually a manifestation after the first few days that may signal deterioration in your patient's condition. Upper respiratory tract symptoms appear to be much less frequent than lower respiratory tract symptoms. Rhinorrhea, sinus congestion are not as frequent with COVID-19 as with other respiratory viruses. And although we are coming out of the influenza zone, it's while mentioning some differences with influenza, myalgias appear to be much less common with COVID-19 than influenza. And fever may not be as sudden in onset as with influenza. Patients with COVID-19 may develop the fever 2, 3, 4, 5 days into the illness rather than the abrupt onset we see with influenza. But again, I want to emphasize there's no particular manifestation or constellation of symptoms that is diagnostic of COVID-19. Other reports out there point to anosmia and loss of taste as a manifestation of COVID-19. So if you have a patient with sudden loss of smell, especially if they don't have any nasal obstruction, any signs of allergy, that could be an early sign of COVID-19. These are case reports. Same with conjunctivitis. I don't know if we should call it conjunctivitis, but definitely it's been reported some conjunctival injection, hyperemia of the conjunctiva, which may be seen in patients with more severe disease. Case series from China report that up to 10% of patients may initially present with gastrointestinal manifestations, nausea, vomiting, abdominal pain, diarrhea. More frequently than not, these patients will go on in the next couple of days to develop the respiratory symptoms of COVID-19, but the first couple of days, their symptoms may be restricted just to the gastrointestinal manifestation. Myocardial injury is something that is usually seen in people who are hospitalized, but they've been case reports where patients reported with the predominant manifestation of chest pain and shortness of breath without any other respiratory symptoms such as cough. Myocardial injury is usually defined as abnormal EKG and cardiac enzymes, usually again seen in people with advanced disease who are hospitalized. Let me move to testing a little bit. We have seen some limitations in testing in terms of the availability of testing. That seems to be improving. In terms of the turnaround of testing results, that also seems to be improving, but also in terms of the accuracy of the testing. There are reports out there that up to 30% of the patients we test may be false negative. So that's important to keep in mind in the particular patient that you may have a high pre-test suspicion for COVID-19, that maybe you should treat them as such and isolate them even if the testing is negative. Some people we will test, and if they're positive, we'll treat, isolate, and contact trace for COVID-19. If they're negative and you still have a high suspicion, then you may want to classify them as person under investigation and still proceed with appropriate isolation. And if the turnaround continues to be a problem, you may have a significant number of patients that are in limbo waiting for those test results to come back. I think initially what we were seeing was up to 2 weeks delay with the commercial labs. I think the turnaround has improved, so hopefully that problem is gonna be eliminated down the road, but we're still dealing with people waiting for their test results to come back. In some situations, the test may not be available, your patient may not be able to get to a testing site, or you may decide that the test is not gonna change your management. Let's say you have a household member of somebody who is already diagnosed with COVID-19 and they're exhibiting symptoms. In all likelihood, they have COVID-19 too, so you may decide to defer the testing for them. So if the test is pending, it's negative, unavailable, or you deferred it, but you consider your patient to be at high risk, then there's still what we call a person under investigation. And at least for the purposes of isolation, we should treat them as such. Let me just spend a minute discussing respiratory virus panels. We have largely gone away from doing RVPs on our patients nowadays for several reasons. I think one reason is to save equipment, testing swabs for the people who need to be tested for COVID-19. Another reason that in all likelihood, that's not gonna change your management. Early in the epidemic, we thought that if a patient tests positive for another respiratory virus, it would be unlikely for them to have COVID-19. But we have seen several cases of co-infection so far. And although the risk of co-infection is low, it's not negligible. So in the middle of a pandemic, testing positive for metapneumovirus or flu or another virus, enterovirus, doesn't guarantee that your patient doesn't have COVID-19. The only virus that could potentially alter your management besides COVID-19 would be the influenza, and we're at the tail end of the flu season. So at this point, we are deferring RVPs in most of these patients. Also, there is a cost side to this. Most insurances will cover COVID-19 testing, but unfortunately, they still continue to charge people for a respiratory virus panel, and the charge can't be up to $1,500 from what I hear. So based on our testing and our suspicion, as I indicated earlier, we classify our patients as COVID-19 positive or as persons under investigation. And we pretty much follow a similar monitoring process. Let me talk a little bit about the COVID-19 population. Once they test positive, we try to risk stratify them. Given that we're discussing outpatient monitoring today, our risk stratification focuses mostly on their risk of having more severe disease and getting admitted to the hospital, and not so much on their mortality risk. So you may see that our stratification system slightly differs from CDC, which focuses on the mortality risk. So that risk stratification into low, moderate, and high risk will determine the frequency of our monitoring. So we're monitoring our high-risk patients daily, moderate risk every 1 to 2 days, and low-risk patients 3 days. We also tried to intensify that the screening in that crucial period between a week and 2 weeks where most people seem to deteriorate. Our stratification scheme is useful in the initial approach to the patient, but after the initial phone call and based on how they are doing and their symptoms, we reallocate them into different risk groups based on how they are doing. And again, one thing about this disease is quite unpredictable. So I've called patients that were presumed based on a review of their comorbidities and age that they would be low risk. And all of a sudden, based on their symptoms, they are reclassified as high risk. And we have had the opposite too. You call patients that based on their age and comorbidities would classify as high risk, and you find out that they're doing quite well. Although a word of caution, the high-risk people I maintain on the high-risk monitoring scheme, even if they're doing relatively well, at least until they get through that rough period between 7 to 12 or 7 to 14 days. We tried to utilize a lot of telehealth. Most of our visits are phone visits, but I strongly encourage using a video platform, especially if there's any concern that your patient is deteriorating. You want to take a look at them and their breathing patterns. We try to get as much vital signs at home as possible. Most of our patients have thermometers. A lot of them have blood pressure cuffs as well. Some of them have pulse oximeters. I think there was a push from the hospital to get pulse oximeters out there. We haven't been as successful so far, but we're working on that. And if they need to be seen, but you're not certain whether they would need to be admitted, we do have an acute COVID clinic. As we have consolidated our outpatient internal medicine practices, that left some areas open in one of our facilities to be converted into a COVID clinic with negative pressure rooms and virtual stethoscopes, a radiology suite. There's also an outside tent where people can be evaluated. We reserve that for the PUIs. We can see PUIs and COVID-19 positive patients in the acute COVID clinic, but we try to separate them because conceivably PUIs may not have COVID-19 and we don't want to expose them to that. So the PUIs sometimes are seen in the morning and then the COVID-19 patients in the afternoon. I would leave more details about the COVID-19 clinic for another echo session. We also have different areas where people can get x-rays in an infectious control process, both for COVID-19 and PUIs. So this is our risk stratification system. Obviously, as I indicated before, our focus is in identifying the people who may need hospital admission. A huge contributor to this risk scheme is age and comorbidities, especially immunosuppression. But as I said, this serves the initial classification, and after that, the symptoms become the major driver of the risk classification for our patients. We do classify pregnant women as moderate risk, although their outcomes are not necessarily worse than low-risk individuals, as they may have special needs that we may need to be aware of by conducting them more frequently than our low-risk individuals. There's also a huge social component to this. We assess whether our patients have adequate supplies at home, groceries, medications, disinfectants, and based on their social situation, we may reclassify their risk as well. Another thing that is not listed here, and we've been observing by monitoring these patients frequently, is emotional distress, and that may also contribute to us reclassifying them so they can get more frequent phone calls. This can be a very stressful period for patients who test positive. There are, excuse me, they're aware of the possible outcomes of this disease, and they may become extremely anxious, and they may need our support more frequently than based on their underlying risk for poor outcomes. So we have developed a phone script that all our callers to these patients try to follow. We want to know when their symptoms started. Obviously, that will guide you as to when that crucial period may come that they may deteriorate, but it may also guide you, importantly, about when they may be ready to come out of isolation. For most of these patients, we do follow the CDC guidelines. They have to be at least 1 week from symptom onset. They have to have at least 3 days without a fever, and the rest of their symptoms have to be improving. If there is any even minor question mark in our mind, we try to extend the isolation if feasible. If we have any concerns that not all of their symptoms are improving. Obviously, for healthcare workers, other essential workers, that isolation period may need to be extended, and there may be different criteria for them being able to return back to work, and we encourage them to work with their employee health in that regard. So we want to screen them for any fever. Most of our patients are able to take their temperature at home, symptoms. We talked about cough. Dyspnea may be an early a sign of deterioration in these patients, wheezing, hemoptysis, confusion, gastrointestinal symptoms. We want to screen as to whether there's anybody else in the household, and if they are not symptomatic, they haven't been tested positive, we want to isolate the patient from the rest of the household, which could be a challenge. In an ideal situation, you want the patient to be in a separate bedroom, use a separate bathroom, not touch shared surfaces, and use a mask if they're in shared spaces. So that can be very challenging. We see a high rate of infection in household members, unfortunately, and a few of the patients we're monitoring, the whole family is basically infected, which creates additional challenges. How do they get groceries? How do they get supplies? So that's part of the next question, how easy it is for them to maintain home isolation. Are they able to air the bedroom they're in, air it out and disinfect it, and what kind of support they need? Thankfully, we have a social worker that can work with these patients. Sometimes we utilize the Central Pennsylvania Food Bank for groceries, or another one of the commercial vendors that can deliver groceries to these patients. Let me talk a little bit about contact tracing. We have another group in our institution that is conducting every patient that tests positive for COVID-19 to see whether there has been any contact tracing performed by the Department of Health. I think the Department of Health is still doing contact tracing, but given the numbers that we're seeing in Pennsylvania, I don't think they're able to do it on every single patient. So there's a group mostly consisting of medical students that is calling the patients and offering them contact tracing. We focus on close contacts. Those are the highest risk, especially household members, and contacts in facilities where the patients may work, such as healthcare facilities, long-term care facilities, correctional facilities. I'm gonna go back a slide, actually 2 slides. I don't know if Dr. Hempel is on the call and if she wants to talk a little bit about the PUIs. I forgot to mention that we have a group also that is monitoring the people under investigation. They're following very similar process to the COVID-19 positive patients, but it would be interesting to hear if Dr. Hempel is on the call, how that group of PUIs was formulated based on the phone calls we were receiving and how we're monitoring them.
Hi everyone. Thanks for having us. We're excited to share a little bit about our process. As Andreas mentioned, I'm Alina Hempel. I'm also part of the General Internal Medicine group at Penn State. One of the things we did early on when the calls for COVID started to become more frequent in our clinic is we set up a messaging pool in our electronic medical record Cerner Power Chart that allowed our nurses and front desk staff to kind of have one location to send messages from patients who are either calling in or sending in portal messages, complaining of symptoms that may be consistent with COVID. We realized the volume of those calls would quickly overwhelm the capacity of the nursing staff to be able to do the normal triage process. And so we started training our residents initially, and then eventually groups of providers, physicians, APPs, nursing staff to be able to help us with the screening process. And they go through screening questions similar to the questions Andreas presented to find out about the patient's risk of actually potentially having COVID. Those questions and our kind of process for deciding about testing has definitely transitioned, significantly changed over the course of our experience and as there's been more community spread. And at this point, what our screeners are doing during that initial call is actually going through that same risk stratification process that the COVID positive patients are going through to try to put them into these risk categories as well. And after that, we're really using a very similar process as for the COVID positive patients to try to ensure that these patients who may not have been tested or maybe waiting for test results are also getting close follow-up. We recognize that they may be equally vulnerable because they're in that phase of time while they're waiting for the test, during which they can decompensate. And so we wanted to make sure that we were catching them if they were starting to decompensate at home early as well. So otherwise, the rest of the process is almost exactly the same in terms of how often we call and the phone scripting we use to try to maintain some consistency and allow for the same groups of providers who are making these calls to be able to do them both quite similarly.
Okay, thank you, Dr. Hempel. Let me just re-emphasize the value of telehealth. Obviously, the health of our patients is a priority, as always, but we want to provide the best health to our patients in the safest way for the providers as well. So anything that we can do remotely, that is preferable than having to bring these patients into the acute COVID clinic or the hospital. And again, the risk stratification is extremely important. Also looking at that critical period, studies show that median of 7 to 12 days after symptom onset, that's when patients, especially your high-risk patients, may start to deteriorate. Rapid deterioration is not, it's actually common. Once they develop shortness of breath, they can deteriorate pretty quickly. So we have to be especially careful during that period. Shortness of breath is usually the hallmark of the deterioration. Sometimes there may be other symptoms, wheezing, intractable coughing, hemoptysis, confusion if they're becoming hypoxic. And again, we want to get as much vital signs as we can at home. If they have a pulse ox, that's even better. But you do want to do a telehealth visit using a video platform if possible. We're using Amwell here, and also sometimes we FaceTime people just to assess, you know, are they tachypnic? Are they using accessory muscles? Do they have conversational dyspnea? Do they have rest dyspnea? You want to take a good look at them as much as possible. And obviously, if you can't make up your mind whether they're stable enough to stay at home or they need to go to the hospital, then we have the acute COVID clinic where people can be evaluated there. I'll just briefly go over, and my focus again is on outpatient management, so I won't mention any of the treatments that are used on the inpatient side. I'm going to preface this by saying there's no solid evidence for any of these things that I'm going to talk about. We are all learning as we go. So let's start with antibiotics like azithromycin or doxycycline. I may utilize that on patients who are getting close or they're in that critical period and they may seem to be developing worsening symptoms, but they don't necessarily need inpatient care or in-person evaluation. I may prescribe an antibiotic over the phone just for the possibility of superimposed bacterial pneumonia. We really don't know if antibiotics have any effect on the COVID-19 pneumonia or lung involvement. We don't use hydroxychloroquine on outpatients. I think we do on the inpatient side. There have been 3 studies that have been published, all small ones, and all were done on inpatients. So there's no evidence that outpatients benefit from hydroxychloroquine. I think there are studies underway, and hopefully we'll find out soon. Like I said, all 3 studies were small. 2 of them were positive. 1 of them was negative. So we're awaiting larger studies to make that determination. We're trying to save the hydroxychloroquine for the people who need it in the hospital, for patients with rheumatologic diseases that need it. And also a word of caution, we've seen prolonged QTC intervals in the hospital for patients who use hydroxychloroquine, especially there is concern if you use that with azithromycin. And we mentioned the myocardial injury that these patients may have. That may also predispose them to have prolonged QT. So we need to be careful giving prescriptions for hydroxychloroquine to outpatients without close monitoring. The general consensus currently is not to give steroids to outpatients with COVID-19. There's a concern of suppressing the immune system. Again, they may be used in appropriate situations on the inpatient side. There may be patients who have asthma and they may seem to be exacerbating, and that may be a situation where you may want to use steroids, but in general, the recommendation now is to avoid steroids on outpatients with COVID-19. Patients may find symptomatic benefit from using an inhaler on the outpatient side for their coughing and wheezing, shortness of breath. Nebulizers are a highly aerosolizing procedure, so if they can do it in their own bedroom without exposing anybody else, that's fine. But you don't want the patients at home to be doing a nebulizer in a shared space with other household members. I have no limitations in using cough medications. We have not seen any evidence that says that they may be detrimental, so you can use them for symptomatic control. There's been a lot of discussion about discontinuing ACE or ARBs in these patients. It seems that the virus attaches to the ACE2 receptor on the membrane of the cells. And because those receptors may be upregulated in people who take ACE or ARBs, there is concern that that may exacerbate the disease. Some people argue the contrary, that ACE or ARBs may be actually protective, and there's been no studies looking at clinical outcomes. So I think the major societies in our country recommend if the patient has an indication to be on ACE or ARB, just continue it for now. There's been anecdotal discussion whether NSAIDs may worsen the disease. Again, there's no evidence to support that. If the patient can take Tylenol, that's fine. But if they cannot take Tylenol, I wouldn't deprive them of symptomatic relief with an NSAID. I think that's all I have, and I'll open it to discussion.
Thank you so much for that. We do have a few questions. One came in rather early, and I didn't want to interrupt you. I think it was Jeffrey, concerning clinical manifestation. Is hypercoagulability a clinical manifestation?
That's not something that I've observed in outpatients, but definitely the people who are sick enough and they're admitted to the hospitals, we're hearing from our hospitalists and critical care physicians that some of them are showing some signs of hypercoagulability. There's been some discussion and maybe some application of using anticoagulants in these patients, but I don't think the evidence is there to support routine use of anticoagulants. But definitely on the inpatients, we do see that. abnormalities in coagulation factors, increased D-dimer is also a poor prognostic indicator.
Thank you. Cynthia, if you don't mind me putting you on the spot for those who may not be following the chat, you responded to a question about advising outpatients to prone at home.
Yeah, I'll actually throw that back to Andreas, but you know, I think that we've seen proning in the hospital used anecdotally as a tool to maybe delay or avoid needing to be intubated, as it may improve the lung mechanics when you're in the prone position and improve oxygenation. I think if your patient at home is having lower respiratory symptoms of shortness of breath and you're worried that they're not oxygenating well, I personally wouldn't mess around with asking them to prone at home and get them to the hospital. But I'd be curious what Andreas has to say.
Well, we had an interesting discussion with our group the other day, and we decided that maybe the person who has intractable coughing, maybe not so much short of breath, we can recommend very brief periods of prone positioning, maybe for 20, 30 minutes at a time, to see if that will alleviate some of their coughing. I had one patient anecdotally that said that she felt better by doing that, but yeah, I do understand the concerns. You want to limit that, and you know, especially if they're short of breath, you know, I would not be inclined to do that. The albuterol inhaler seems to help with the intractable cough in those patients, and we've also been, if they have access to a humidifier, that may give them some relief as well, besides the cough medications that they can use over the counter.
Thank you. So Melissa had a question, and I know, Andreas, that you responded to her in the chat, looking for more information about the acute COVID clinic, hours, how do we contact them, any peds available. I believe Emily is online. If Emily, if you are able to unmute and address that, we'd love to hear from you.
Hi, yeah, can you hear me?
Yes, we can. Thank you.
Oh, great. Great. So I was just typing a response, but basically if you're in the Penn State Health Network, the acute COVID clinic is here on campus. It's in a separate building from the medical center. We're open from 8 to 4. We can be reached by Tiger Text. So HMC COVID clinic physician, just give us a Tiger Text. We're happy to discuss any patients you think need an in-person evaluation who don't need to go to the ER. So these patients that I've noticed that if you're talking to them and they're having conversational dyspnea, because of what Andreas mentioned, how they tend to rapidly decompensate, those patients probably more appropriate for the emergency department. But if you think somebody needs to lay eyes on a patient, listen to their lungs, check their pulse ox and vitals, that's what we're here for. We'll see them the same day. And so just like I said, Tiger Text HMC COVID clinic physician. There was a question about peds. We always do have a family medicine physician here. And so we can provide care to any age.
Thank you. Thank you for sharing that. And I know there was a question, again, I'm sorry for repeating, but for anyone who's not able to see the chat regarding the stratification, Gloria asked, do you consider mild intermittent asthma as a comorbidity? Andreas, do you want to follow up a little bit in more detail?
Yeah, I mean, obviously, it wouldn't be as a severe comorbidity as people who have persistent asthma, but as a caution, I would probably still classify that person as moderate risk just based on that, so that they can get more close follow-up.
Thank you. So we have several members of our hub panel here with us today. So if any of you have anything to contribute or add to what Andreas shared, please feel free to do so. I'm going to ask if there are questions before we move into the case. And as I'm saying that, I do see a question. Have you noticed any factors that predict severe illness, sudden decline in young COVID patients?
Yeah, one factor that is not on our classification scheme, and maybe it should be, and because it's in the CDC guidelines, is obesity, especially with a BMI over 40. Obviously, young people, if they have the comorbidities that we mentioned, especially chronic lung disease, diabetes, hypertension, they would be at risk for more serious manifestations. But obesity seems also to be a predictor of worse disease. And again, I want to emphasize the unpredictability of this virus. There's probably genetic variations, immunologic variations that are subclinical, not detected, that predispose certain individuals to have worse disease. So our risk stratification has definitely limitations. That's why your initial phone call to the patient may make the difference whether you want to keep them in that category or you want to move them to a different category.
So Andreas or any of our other panel members or anyone on the line, any breathing exercise recommendations for outpatients?
I haven't seen any evidence of that, but I know that some of the patients, especially who were discharged from the hospital, were recommended to do incentive spirometry. So I think that can be recommended in some patients.
Are there any other questions or comments before we move into a brief case that may prompt additional discussion? Well, I'm going to ask Erica or Ellie to bring up the patient case slides, and I'll continue to monitor the chat and we'll address questions and other comments after the case. So Andreas, I know that this is not your case. This was submitted by someone, so I know you won't have the information around it, but would you mind kind of walking us through some of the key points?
Oh, sure, yeah.
Thank you.
So this is a COVID positive patient that works in a correctional facility and also was shopping at the mall, and there is concern for mass exposure. I think this was compounded by the fact that there was a 12-day delay, it seems, from the time the patient was seen until the results came back. So this is a 40-year-old individual, came to the office, it seems like about 3 weeks ago, with her son. Both had masks on. The symptoms were fever, cough, and feeling drained. Had sweats, and temp was 1.4. She had just returned from Spain and went through JFK Airport and was in a shopping mall as well. And symptoms appeared to be worsening. I think she was seen probably 4 or 5 days after symptom onset, based on the previous slide, I think. Headache, sore throat, dry cough, some dyspnea on exertion, and has history of asthma, so there is a comorbidity there. And daughter is also symptomatic. And she works as drug and alcohol treatment counselor at a correctional facility. And she was there for a week before symptom onset. So just to mention, the current assumption is that patients can be contagious up to 5 days prior to symptom onset, which makes it even more difficult in this situation. I think she was seen initially for a sore throat before the other symptoms developed. And she had positive strep and was placed on Levaquin. So hopefully that wasn't a manifestation of COVID all the way back then. And I think besides the asthma, she has GRD and migraine. These are her medications, and a patient at that point was tested for flu, viral panel, and COVID, and was advised to, I guess the correct term would probably be isolate if they have symptoms, but it's probably the same process as quarantining themselves. Flu was negative, and viral panel and COVID sent out with a 3 to 5 day turnaround time. I guess it ended up being a 12-day turnaround. Yeah, so that's a very interesting case. It illustrates all the challenges we have with the management of COVID positive patients. One of the challenges, the major challenges, has been the turnaround of tests. Hopefully that is getting better. I mean, in the beginning, back in March, when this case is pertinent, we were seeing up to 2 weeks turnaround for tests sent to commercial labs. That's why it's important to be aware that the Department of Health is still running tests, and if you have the patient that meets their criteria, they can perform a test with a more rapid turnaround. I think that turnaround is probably 24, 48 hours, especially for someone that works at a correctional facility. I would think that you can get approval from the Department of Health to run that test more quickly. It also highlights what I mentioned earlier. In this era of a pandemic, we should assume that everybody with a URI may have COVID-19 and treat them as much. So even though the test is pending, that PUI should be isolated and appropriate contact tracing should be done. I know it's very difficult to do contact tracing when somebody has been in a mall, right? I don't know how much you can do about that. You can coordinate with the Department of Health whether they're going to have any environmental cleaning and disinfection for the mall, but tracing all those people that were in the mall, I think that's virtually impossible. Now, with the correctional facility, obviously it's a different proposition. You have to act immediately and contact them even before the test is back to alert them that there may have been some exposure. So the recommendation used to be that we quarantine every close contact of a person that has COVID-19. I think CDC recently changed their recommendations for essential workers, which I think includes correctional facility workers, that even close contacts of people with COVID-19 can go to work with certain conditions. They monitor their symptoms, their temperature is taken, they wear a mask, they social distance, they don't share anything that goes on their head, like headphones or anything like that. So I think that applies to correctional facility workers. The problem with correctional facilities is that isolation of the inmates is extremely difficult. Disinfection is very difficult. And you probably heard the reports of massive outbreaks in jails and prisons, especially I think there was one in the Illinois area. There was a massive outbreak there. So it's a very challenging situation, and I'd be interested to hear if anybody else has any comments on that.
So feel free to unmute or put comments into the chat.
The COVID antibody testing, I think they mean the serological testing. I'm not aware that we're doing that in Pennsylvania yet. I know that they began to do it in New York. I think we're still working through optimizing the sensitivity and specificity of that test. You don't want to roll it out unless it can show the unique antibodies to the virus, not to have any cross-contamination from antibodies to other viruses, and to high enough to probably some immunity to that person. I'm also not aware, and I don't know if Dr. Krasnewski is on, if that's something we are doing for the convalescent patients that we're considering for convalescent plasma treatment. Are those patients going to be tested for antibodies prior to donating their plasma? Maybe there is a limited application that we're doing for them right now.
That's a great question. We are not. The process is actually donation through the American Red Cross, and they're using prior positive testing as well as 28 days of being symptom-free. So if people have taken care of patients who have recovered from COVID-19, this is an awesome opportunity for them to help others.
The sensitivity of chest CT, that's an interesting question, and I don't have an exact number to give you, but I know that in China, they found out that the sensitivity of the nasopharyngeal swab wasn't optimal. So I think at some point they stopped doing nasopharyngeal swabs, and everybody that got admitted to the hospital that had severe enough disease got a CT chest, and they seem to think that at least for the hospitalized patients that had higher sensitivity than the nasopharyngeal swab. Obviously, the manifestations are not very specific, but in the middle of the pandemic, if somebody gets admitted with characteristic symptoms and they have some findings compatible with COVID-19 on their chest CT, you have to assume they have COVID-19. I don't think we've been doing CT scans in our inpatients here. And again, that application is limited to inpatients. You cannot do a chest CT for every outpatient out there with possible COVID-19.
So there's another question in the chat regarding the sensitivity of chest CTs to determine COVID-19 infection if PCR is negative.
Yeah, like I just said, I think there may be some value to that. The sensitivity of the nasopharyngeal swab at best seems to be 70 to 80%. Aggressively was done and how long the swab lasted. And in some other countries, they've opted to do a chest CT on every patient that gets admitted to the hospital. I don't think we're there yet in our country.
Thank you. I apologize for asking you to repeat that. Are there other questions or comments regarding the case or the general discussion?
Dr. Achilleos, this is a little bit off topic, but with routine care, in some ways, I think people are feeling that some aspects of routine care are being placed on somewhat of a temporary halt with the COVID-19 epidemic, and talking to people in different emergency room settings, they have felt that there have been an upsurge of patients coming to the emergency department for things like albuterol refills because of primary care clinic closings, et cetera. Is that something that you have noticed? I know our primary care clinics are still functioning, although it's a little different, but is that a concern? And what can we do to prevent, as we're dealing with COVID-19, what can we do to prevent other diseases from getting ahead of us, other chronic conditions from getting worse in our population?
Yeah, I think that's an excellent point. I haven't noticed that personally in our clinic, but I wouldn't be surprised if it's already happening. I've read and heard the concerns from around the country, and it's not just us. You know, take for example dentists. A lot of them are not providing care anymore. So what happens to patients? Do they end up in the emergency room? I think we try to optimize the telehealth opportunities to still provide care to people. For the patients that have to come in, we have to be able to provide a reassurance that we are separating them as much as we can from people who may have a COVID-19 infection or have already tested positive for COVID-19 infection. I think that's one additional benefit of having the acute COVID clinic, that we don't have to see those patients in the same area that we see other patients. So I think that's it's going to be a challenge the more this lockdown continues, and we're going to have to find innovative ways to still provide care to our patients without burdening emergency rooms, or without having patients staying at home and suffer through illnesses that they shouldn't be suffering through. Yeah, I'd be interested to see any other questions from people about this.
Maria, thank you for bringing that question up. Andreas, I'm not trying to put you on the spot all the time. Remember, we do have a whole team, so please, any of our panel members, feel free to jump in. There's a question from Bill regarding pathological specimens from COVID victims. What have they shown?
I have no clue. That's my honest answer. So if anybody else has an insight, then please share. I'm sorry.
And if no one does, we can try to follow up on that. But again, anybody from our panel or any of our participants, again, I'll teach, I'll learn.
I can just say I was looking up one thing in particular, which was that there's been some talk about maybe a hypercoagulable state in patients that are COVID positive, and some centers are considering placing patients on full dose heparin instead of just prophylactic dose. And so the one part of the autopsy specimens that I was looking up was whether or not there was any increased thrombosis that was seen in any of these patients. And there was not any increase, either micro thromboses or in the larger vessels. And so that perhaps goes a little bit against the necessity to consider putting people on higher dose anticoagulation, but I don't know any more depth than that.
Thank you for sharing that. And do you want to look at the second question that came in? Is there respiratory data for tissues of deceased COVID-19 patients worldwide?
My suspicion is there is, but I don't know what it would show. I haven't looked into that. If anyone else may have, but I haven't.
So again, if anyone has anything regarding that, please share it, and we will always follow up afterwards with our emails and our resources. So another question, what active research protocols involving COVID patients are ongoing, outpatient or inpatient at Penn State?
Actually, I'm thrilled that this question came up. We're considering another session to tackle exactly this. So it seems like that may be of interest. It will be featuring a whole team of folks, including our wonderful Dr. Kroc, who just answered the last question, who's really operationalized these protocols. There are protocols that are available to all hospitals, including the Mayo and FDA partnership on convalescent plasma for treatment, which I mentioned earlier. And this is a combination between research protocol and emergency use access for the plasma. So it's a really fantastic way to have easy access for hospitals patients. In other inpatient that we are participating at Penn State are the NIH's remdesivir trial for patients with severe and acute life-threatening disease. And outpatient trials are being investigated, but those are the current protocols.
Thank you. So we have 2 minutes left. Are there last minute questions or comments? I do want to mention that I think I said respiratory, it's repository data, and that's duly noted now. Thank you. Are there any questions?
Yeah, it's Cynthia. If I could chime in too, to add on to Jen's list of studies, Penn State was also selected to participate in the PCORI funded HERO trial. So the HERO trial, I'm sorry, I'm forgetting what HERO stands for. It does stand for something, but it's actually going to be a prophylaxis trial for healthcare workers that are in high-risk patient care situations of hydroxychloroquine versus placebo times 1 month, looking at clinical outcomes of clinical conversion to COVID-19.
My apologies for forgetting that one. It's an amazing trial, and thank you for leading that effort for us.
Thank you. Thank you for sharing all of that. So it is 8:59. A few closing announcements. First, thank you, Andreas. Thank you to the rest of the panel and all of our participants. We certainly appreciate you taking time to be here. A reminder that you're able to collect CMEs for today's session. We hope that you will join us for our next session. It's scheduled for tomorrow at 9 a.m. Dr. Gavin McGregor-Skinner will discuss crisis standards of care, decisions that are facing healthcare workers, and allocating scarce resources. We also have a session scheduled on Monday with Dr. Jamie Pauley, who will discuss COVID-19 during pregnancy for providers. So if you have a patient case on that topic, please let us know. You can contact us at echo@psu.edu, or you can respond in any of the emails that we send following our sessions. So thank you again for your participation. Stay safe, and we hope to see you soon.